So we're going to go through a lot of the background, just general knowledge about Chiari malformations. This lecture was really focused on what is Chiari or what are the Chiari malformations, rather than predominantly in treatment, which will be covered in the next lecture in this series. So we're going to talk about the epidemiology, the different types of Chiari malformations, some of the pathophysiology, our radiographic findings, and then some of the current scoring systems that we have out there to evaluate patients with Chiaris. So I wanted to start this with a case. So this was a 9-year-old male, had a history of asthma, swallowing difficulties, and dysphagia. He was admitted after an asthma exacerbation and had a presumed aspiration pneumonia. And he had this kind of vague history of sort of these diffuse intermittent headaches. They were worse with coughing. They were always in the occipital region. They were always radiating down his neck. He only got some relief with ibuprofen. He had no other numbness, tingling, no pain. And then he initially reached potty training at age 3, but then starting at age 4, he would have just this nocturnal enuresis. And then after he had a swallow evaluation, he was basically put on a thick and liquid diet. So during this admission, they also noticed a couple abnormalities on his exam. So on far right lateral gaze, he had nystagmus. He had an absent gag reflex. He had some difficulty with his tandem gait. And then when you actually got down to it, even though he didn't complain of any subjective numbness, he did actually have decreased sensation to pinprick in both of his arms and legs as compared to his face, but otherwise was intact with no motor deficits. And then this was his scan. So you see a couple very characteristic findings here. Hopefully you can see my cursor, but on a sagittal T2, of the cervical spine, you have pons and medulla, and then you have the cerebellum back here, and you see this kind of elongated portion of the cerebellum extending down into the upper cervical canal. In addition, you see this hyperintensity within the cord that tracks all the way down, and this is kind of a cross section of that. Upon further imaging all the way down, you can see that hyperdensity in the cord really extends down to the mid-thoracic spine. So of course, what is his diagnosis? As a clue, because we were talking about Chiari's, his diagnosis is a Chiari 1 malformation with associated syringomyelia. So just to give kind of a brief reminder of our posterior fossa and cerebellar anatomy, I know the posterior fossa predominantly made of the occipital bone in the back here. That's our primary concern from a surgical standpoint, the foramen magnum, the opening at the base of the skull. And then within our cerebellum, you have these two little areas called the tonsils along the medial aspect of the cerebellum, just ventral to the cerebellar hemispheres. And then just as a reminder of our standard CSF flow, we have 2 lateral ventricles that sit within each of the hemispheres. They drain through the foramen of Monroe into the 3rd ventricle, which then drains out through the aqueduct down into the 4th ventricle, which has 3 outflow areas. The middle outflow, the foramen of Magendie, and then the 2 lateral foramina of Luschka. And when we think about it, this is really the area that we're most concerned about with a Chiari malformation. So the history of Chiaris, this was first discussed in the 1890s. Hans Chiari noted that there were 4 different abnormalities that he discovered at the time of the rhombencephalon development, and a lot of them had just common features of impaired CSF flow through the foramen magnum. So he coined those 4 different types. Chiari 1, he described as the herniation of the cerebellar tonsils below the level of the foramen magnum. The Chiari 2 was herniation of the cerebellar vermis, that midline structure, as well as the medulla below the level of foramen magnum, and this was predominantly seen in patients with myelomeningocele. Chiari 3 was in occipital encephalocele, and Chiari 4 was complete absence of the cerebellum. So for the purpose of this lecture and for most of the discussion on Chiaris, we're going to talk predominantly about the Chiari 1 malformations. We know that Chiari 2s, because of their association with myelomeningocele, they're we treat them a little bit differently than we do Chiari ones. So when we're comparing kind of the most common types of those, the Chiari 3s and Chiari 4s are fairly rare. Here's kind of our normal with a cerebellum and a wide open foramen magnum, lots of room for CSF flow. In the Chiari 1 malformations, you have this herniation of the tonsils down in through the foramen magnum. The fourth ventricle is obstructed, and then you have the syringomyelia that can develop in the spinal cord. And then with that Chiari 2, this is actually going to be the vermis and some of the cerebellar tonsils. You can have some beaking of this tectum right down here, or the beaking of the tectal plate, and downward displacement of the brainstem through that area. Oftentimes you'll see associated hydrocephalus within that. And you see kind of this elongation of the fourth ventricle all the way down, it as well as the downward displacement, because it's a true elongation of the entire brachmencephalon down, including the medulla. So our Chiari 1 malformation, the characteristics, like we discussed, it's herniation of the cerebellar tonsils below the foramen magnum. It doesn't have to be completely symmetric. In fact, oftentimes these patients will have a little bit of asymmetry with one tonsil herniated a little bit more. They can also be associated with many skull base and craniovertebral junction abnormalities, atlanto-occipital assimilation or fusion of the C1 to the skull base can be seen in this population. Clivoaxial deformity with abnormalities in the bony elements of the cervical spine. Some of these kids will have retroflexion of their dens. And I always say kids because I'm a pediatric neurosurgeon, but obviously this occurs in adults too. You can see ligamentum flavum thickening. You can see issues with fourth ventricle outflow obstruction. We do see some variation in the tentorial slope, which we think probably has some component to it because we think that this is generally a posterior fossa volume issue. You can see associated syringomyelia, and subsequent to that, you can also see associated scoliosis. So over time, we sort of had this evolving understanding of Chiaris. We started with those 4. And then we noticed that there were also the subset of patients with a syrinx that didn't have the characteristic features of Chiari, but would respond to a Chiari decompression. So they sort of made their own little subset. And then we noticed that there was this other little subset of patients that had kind of some of those same features of the Chiari 2, where their brainstem was elongated, it was displaced into the foramen magnum. The obex of the fourth ventricle was down, but it was still the cerebellar tonsils, and they didn't have a myelomeningocele. And so there was this kind of like middle group somewhere between that Chiari 1 and Chiari 2. So of course, what do? We just added to the classifications. The syringomyelia that responded to a Chiari decompression where there wasn't actually a Chiari naturally became a Chiari 0, and the Chiari that was somewhere in between a Chiari 1 and a Chiari 2 became a Chiari 1.5. So something made sense when they were adding to this classification. So this is kind of the classic Chiari 1.5 malformation. So you see kind of the pons, and you see this sort of elongation of the entire medulla. And so this is that medullary bump right at the base. You can see that the fourth ventricle itself is actually elongated and displaced down. This is our retroflex dens. So the foramen magnum is sort of right here. And you still have those cerebellar tonsils herniated down, but this has a little bit of a different morphology than our classic Chiari 1. And oftentimes this is associated with a kyphosis of a craniocervical angle. And so we'll talk a little bit more about that down the road. So when we think about this, because before we really understood the kind of this sort of separate entity of a Chiari 1.5, a lot of the epidemiological studies sort of lumped all of those into that Chiari 1. So there is limited epidemiological studies out there. We think the prevalence is somewhere around 1% of the population. But it's also kind of isolated to the population of people that are getting imaged. So whether it's slightly more prevalent or slightly more rare, it is sort of lumped into that group of people that are being imaged for some other reason. When we look at those people that have Chiaris, the syrinx can be described anywhere in 22 to 70%, depending on what the study you look at. But in certain studies that had looked at patients that underwent surgery for Chiari, that is actually a much higher prevalence, though about 60 to 80% of the patients who actually require surgery for their Chiari had a syrinx, and typically a syrinx is usually an indication for surgery when we're thinking about how to decide on intervention. And then the other portion of this is that this is all sort of the same, kind of all in the same line. About 14% of patients also have a concurrent tethered cord, and that can be anything from fatty phylum to lipomas. So we do know that there's some association with that as well. So when we think about that, the etiology, we're still sort of trying to figure out. We think that it's a congenital issue. We think that it has to, this is a static type of picture. We usually don't anticipate that they're going to change much, except when kids have some skull growth. We do allow for some differentiation between very young children versus older children as far as what we would classify as a Chiari. But we also see this develop secondarily to other issues. So chronic shunting, and related to Chiaris that are secondary to craniosynostosis. We think that both of these kind of create a similar picture of craniocephalic disproportion. So when the skull is inadequately sized for the brain, that can be something that can cause that. Lumbar shunting can induce Chiari malformation as well, so not just ventricular shunting. We see this secondary to craniovertebral junction abnormalities and other abnormalities of the skull base. We can also see this with tethered cord, and then similar to lumbar shunting, patients with an occult CSF leak can actually develop a secondary Chiari from their CSF leak. And it's really important to understand that when you find a Chiari malformation, you really have to think about what the etiologies could be. So understanding the history of that patient, somebody who did very well, had maybe a history of several spinal taps for other reasons, and then started presenting with this, it's possible that they had a Chiari and became symptomatic because they had a spinal tap, but it's also possible that if this was discovered sort of afterwards, that they could have a persistent CSF leak. So thinking about that and understanding how important that history becomes in looking at, the potential underlying etiology. And that becomes important when you start to think about treatment, because although we have a surgery to treat Chiari malformations, if the Chiari is secondary to something like craniosynostosis, we oftentimes think we need to treat the craniosynostosis and expand the skull rather than immediately going to the Chiari malformation. So our pathophysiology, as I like to describe it, the symptoms fall into one of kind of three main etiologies. So it's either from direct compression of the neural structures as they're crowded in the foramen magnum, and that can be things like myelopathy or bulbar signs. They can be symptomatic because of obstruction of CSF flow. Those we think cause the tussive headaches. That can also cause a secondary hydrocephalus if it becomes obstructive in nature. And then we think that kind of the third way we think about this is if the CSF dynamics become altered. As I like to explain to my patients, this is kind of akin to if you had a garden hose and put your thumb over the tip of it, all of a sudden the water is just spraying rapidly around there. So that change in how CSF is flowing around the foramen magnum, we think actually impacts the hydrodynamics of CSF around the rest of the spinal cord. And that can be what can kind of induce the syringomyelia by causing the CSF to sort of back up into the spinal cord because of those alterations. So when we talk about bulbar symptoms, that's typically from ventral brainstem compression, all the cranial nerves that are kind of seated more ventrally within the medulla. That's anything from vertigo. Patients will have that kind of diplopia if they have abnormal gaze. They can have dysphagia from their glossopharyngeal nuclei. They can have apnea, and we typically consider this to be central sleep apnea. A lot of these patients may have concurrent obstructive sleep apnea from something else, but it's usually the central sleep apnea that we're concerned about. And then myelopathy. In addition, some of these patients will have vasovagal symptoms or hyperactive vasovagal responses. So that brings us to, well, what do we do for our workup? Typically they will come to you with either an MRI of the brain or the spine. One of those is usually how this was found. I can tell you in my pediatric practice, it could be kids with chronic headaches get an MRI brain and it's discovered. Children with scoliosis get an MRI C-spine or cervical and thoracic spine, and that's how it's discovered. But typically, whichever is done, I will usually complete the rest of the workup. And because of the association with possible tethered cord, I will usually scan the entire spine. Some will just do cervical and thoracic spine. But understanding the prevalence of syrinx in this, about 50% of kids that have a syrinx can have it actually in the thoracic spine. So simply scanning the cervical spine may not actually show all of the pathology that's potentially involved. There are also MRI Cine flow studies that look at CSF flow through the foramen magnum. I have not found those typically as helpful in diagnosing a Chiari because most Chiaris are. It's more if I have a patient that has some sort of vague symptoms, a not very impressive scan, and I just want to verify that there is flow. And then in patients that don't really have any radiographic reason, so they don't have a syrinx and I'm not yet considering surgery, and perhaps their symptoms are not severe and we want to try conservative management or medical management of headaches, I'll typically consider maybe a swallow evaluation or a sleep study just to make sure that there's not any occult aspiration or central sleep apnea that would be concerning, that would be kind of lean me in the direction of surgery when I otherwise would not be considering it. So that's kind of how do we, once we get these patients in, how do we measure the patient impact? How do we measure the impact that we're having on their life? And how do we measure how severe their symptoms are? And how do we measure how their outcomes are? So those are kind of the three main categories where we have validated grading scales. The first is the Chiari Health Index for Pediatrics. It's a quality of life index that's specifically designed around Chiari malformations and symptoms specific to Chiari to assess the daily function and quality of life. The Chiari Severity Index was developed to try and predict outcomes following surgery. And then the Chicago Chiari Outcomes Scale is a measurement tool to evaluate outcomes following surgery, and it uses 4 different parameters. So we'll talk about each of those separately. So the Chiari Health Index for Pediatrics, this was developed out of Vanderbilt University. It is a 45-item questionnaire, and it's specific to the quality of life measures for patients with Chiari. So there are a lot of quality of life measures out there that have been validated. But this was really focusing on those types of symptoms that most impact the quality of life of this patient subset. There are 2 primary domains. They include the physical domain, which has to do with the pain frequency, the pain severity, and some of the non-pain symptoms that they're having, and then psychosocial domains. So you can see this is actually the entirety of the questionnaire. It has everything from headaches or pain in back, arms, legs. And it's both how frequent that pain is occurring and how severe the pain is occurring. Some of the non-pain symptoms are usually those activities of daily living, handwriting, raising your arms, walking, playing sports, or sensation, tingling, numbness, trouble with your swallowing, going to the bathroom frequently, losing your balance, and then general activities of daily living. And then the psychosocial has everything to do with kind of their mood and their feeling, interacting with other children, and kind of how they're doing in school and different schoolwork. So this was validated to measure health-related quality of life over time. And it actually was shown to correlate with changes in symptomatology. So as the symptoms improved following treatment, the health-related quality of life as measured by this improved. And this was greatest when they were validating this. This was noted to be greatest in patients that presented initially with neck or back pain, with headaches, and those patients that had a syrinx. So those were the patients that ended up doing the best following decompression. The Chiari Severity Index. Now, this was developed. It was sort of retroactively developed. So what they did is they looked at this cohort of patients and sort of figured out how they did and kind of lumped them based on a couple different categories. And in doing sort of multivariate analyses of different presenting symptoms, they were able to find out which symptoms correlated in their cohort with patient outcomes. So looking at the patient outcomes and then working back to initial presenting symptoms, they developed the Chiari Severity Index. And so this was intended to be used before surgery to assess potential for improvement in quality of life. So it's very important that the outcome measure that they were looking at was quality of life outcome. So not specifically just symptomatology. So initially they wanted to evaluate kind of two main categories. They wanted to look at the clinical information, which was predominantly the headache and myelopathy, but also the radiographic information. So the level of tonsillar descent and the size of the syrinx. And so when they looked at all that, the headache, myelopathy, and the syrinx size had the greatest correlation with the quality of life following surgery. And so they lumped these into three different categories. So they had kind of this, the clinical grade was graded 1 through 3. And that was, grade 1 was either that classic occipital Chiari headache or generally kind of poorly localized headache. Clinical grade 2 was a frontotemporal headache or no headache at all. And clinical grade 3 were patients that predominantly had myelopathy. And then the neuroimaging grade had to do with either an absence or a syrinx that was less than 6 millimeters or a syrinx greater than 6 millimeters. And that was category A and category B. And what they found is this sort of this classic Chiari headache, no matter what size of the syrinx, had the best response to surgery. So these had the biggest improvements in quality of life. The next group were those patients with small syrinxes that either had kind of not that classic Chiari headache or no headache or myelopathy. And the patients that had the least improvement in their quality of life were the large syrinx with either frontotemporal headaches or myelopathy. And so this was developed based on this. And this is really looking at postoperative quality of life rather than the true clinical outcomes. So there's still additional studies looking at how well this is as a predictive tool. And again, some of the studies that are looking at back are comparing kind of clinical outcomes rather than quality of life, which is not what it was validated for. So it's important when you use these types of tools to understand how they were designed and what they're intended to predict or measure. And then finally, the other main tool that we have is the Chicago Chiari's Outcome Scale. So this is a postoperative clinical outcomes measurement. So this is based on their clinical outcome, not a quality of life measurement. So it evaluates things in 4 categories. They have pain symptoms, which included anything like their tussive headache, if they had neck or shoulder pain, any dysesthesias of the upper extremities. They had a category for non-pain symptoms, which were dysphagia, ataxia, vertigo, weakness, sensory loss, if they had any paresthesias, tinnitus, if they were having drop attacks, or if they actually had a syrinx, so radiographic evaluation. The third category is their overall function. And then the fourth category actually brought into consideration if they had any complications from the surgery. So this was created as a 16-point scale. The range is 4 to 16. So each one of those, you can get a 1 to a 4. And so 1 in the pain and non-pain symptoms correlated to worse postoperatively. So whatever their pain was became worse postoperatively to unchanged, improved, or completely resolved. And then from a functionality measurement, if they were either unable to attend school or work, if they had moderate impairment, mild impairment or if they were fully functional. And then the complications were anything that, persistent complications being kind of the lowest score and no complications being the highest. So this is one of the ones that's actually been looked at as, is this a predictive measure? And overall, if you kind of take all comers and Chiaris, we think there's probably a greater than 70% chance of achieving a good outcome. And that was defined as a score greater than 11. So if you kind of look at this, again, most of those symptoms are going to be improved, if not resolved, with minimal impairment and either only a transient complication or no complications. And then when they were looking at kind of the individual symptoms and what was least likely to improve or have a good outcome, if they had dysesthesias or paresthesias or hyperesthesias, they were more likely to have a poor outcome. And we figured out that the degree of herniation really doesn't correlate. We've slowly been figuring that out over time. And then patients with the syrinx actually do the best. So those are the most likely patients to experience a good outcome. And then children, more so than adults, are more likely to experience a good outcome. So that kind of takes us through the initial kind of discovery of Chiaris, are the evolution that we have of understanding the different subtypes of Chiaris and how we measure their improvement. But there are still those patients that, despite everything that we do, they don't improve. And that is really where a lot of our understanding has kind of come forward in the last decade or so. So I'll bring up another case. And this is a 15-year-old female. At her high school screening, she had scoliosis. She had kind of these vague history of headaches and back pain. And so her MRI, her PCP ordered an MRI. And here was her MRI. And it's the same sort of thing that we were seeing. This herniation of the cerebellar tonsils, there's a syrinx in her cervical spine. You can see kind of a little bit of abnormality in just the general alignment of her neck. So the remainder of her imaging was unremarkable, except some scoliosis. So she was treated. Standard Chiari treatment, a suboccipital decompression, a C1 laminectomy, a duroplasty. The tonsils were shrunk. And this was all done before I came to know her. And she did great for 3 months. And then all of a sudden, she started having some left-sided neck pain. She had a new onset tachycardia and was having these intermittent palpitations. She was having some dizzy spells, lightheadedness. She was diagnosed with POTS. For those of you that have not yet done a PEDS rotation, this is basically just like lightheadedness in a teenage population. And then she had the onset of these frequent hiccups, and she would have several episodes of hiccups that would last for hours, and frequently would end up in the emergency room because she couldn't get them to stop. So she got another MRI and her syrinx was gone, and you can see she's well decompressed. She had a Cine flow study. There was great flow both in front of and behind the cord at the foramen magnum. And so this, in all of the things that we think about, this is somebody who had a very successful surgery. Everything looks great. Radiographically, she looks fantastic, but she's got all of these symptoms. So this was kind of way back. This was, the original thought of there's something that we're missing. And this was done. There were 40 pediatric patients, and they had all were noted to have a retroflexion of their dens. And this is a PBC2 line. So this is one of the measurements that we do in Chiaris. And all of them were over 9 millimeters. And these kids, after Chiari decompression, were these kids that ended up needing craniocervical fusions. So occipitocervical fusions. And so this really led us to an identification of another category of Chiari. And so this is where we get into complex Chiari malformations. So we have a lot of things and a lot of findings that will throw somebody into this category. And that's that Chiari 1.5 malformation. If they have kind of a medullary kink, so their kind of medulla is kinked over their anterior skull base. We do know that serings and scoliosis contribute. If they have any sort of basilar invagination, that retroflexion of the odontoid process, if they have any abnormalities of their clivocervical angle, the occipitalization of the atlas, and these other craniovertebral junction abnormalities. So these all kind of fell into this complex Chiari malformation group. And so we need a little bit of a refresher or an introduction to basilar invagination if you've not yet had education on this. But there's kind of three main things, three ways that we think about that. And ultimately underlying this is what we think is the pathology in this is that the release in surgery of this posterior tension band, it causes either progressive craniocervical settling, progression of basilar invagination, or just a small amount of instability in the sort of micromotion that puts these patients at risk for developing craniocervical junction instability after a decompression. So what's next for our patient? So she, of course, went to neurology because they weren't sure what was going on. They got a 24-hour EEG. They were wondering if she had some weird sort of vagal nerve compression that was causing. And then they got us involved. And the only thing that was notable on her exam was just this sort of frequent episodes of hiccups. So she got the gamut of everything, again, with the onset of neck pain and all of these ventral brainstem signs that she was having, my concern was that she had developed this craniocervical instability. So I got flexion extension x-ray, she got a CT of her C-spine, she got flexion extension MRI to take a look at everything. And why did I put her through all of that? Well, when we think about it, there's kind of this slew of symptoms that should cue you into the possibility that after Chiari decompression, any of these new symptoms could mean that somebody has developed basically occipital-cervical instability. So recurrence of their occipital headache, in particular neck pain, if they develop new myelopathy or hyperreflexia, if they have any sort of posterior column dysfunction, if they have a downbeating nystagmus or change in their gag reflex or dysphagia. So all of those bulbar signs that were occurring before, if these are new following decompression, you have to be a little bit concerned, especially in the setting of a patient who had complete resolution of her serings and adequate CSF space around her cord. So those parameters that we talked about, so McRae's line, if you draw a line at the skull base, the dens should not extend above it. So this is a sort of yes or no, it does or it does not criteria for basilar invagination. And then the two parameters that we use predominantly in these complex Chiaris, the PBC2 line is a line drawn from the tip of the basion down to the posterior aspect of C2. And then it's a measurement, a perpendicular measurement from that line to the point of maximum posterior extent of the dens. This is typically done, you can see in this is done on MRI rather than CT, because you also want to capture any of that kind of soft tissue that's within that measurement. So if you do have patients that have a little bit of instability, they can develop kind of hypertrophy of the soft tissues or a pannus, and you want to make sure that you're including that within that measurement. And then the clivoaxial angle, if you take the line drawn parallel to the bottom 2/3 of the clivus, and then a line that's drawn parallel to the posterior aspect of the dens, it's that angulation between that measurement. So this was kind of her flexion extension, and you can see when she extended, it's not a ton. Her ADI didn't really change that much. That's at 2.2 and 2.3 millimeter. But you can see kind of how much she's kind of moving at that. And to some degree, we think that there's some motion that's normal there. But with this, in kind of this entire setting, and if you look, this left picture is actually her in neutral and fairly kinked over. So she was someone that I put in a hard collar or a cervical collar, just to see if I could give her a little bit of extra support. And then if she didn't have any resolution in her symptoms, I was going to try her in cervical traction to see if that could stop her hiccups. But after about a week and a half in the collar, her hiccups completely went away. So that sort of gave me the answer. And so, then you have to have this talk with them of, I think we're heading in the direction of an occipitocervical fusion. But now we've done, thanks to the group at Utah, we have a ton of information that really gives us a better idea of who's at risk for this. So in their group, they looked at 101 different patients with Chiaris, and 19 of them required an OC fusion. And the indications were anything from bulbar symptoms, myelopathy, either an unresolving or progressive syrinx. So that was kind of how we first developed this hiccup case. Was a sort of weird one. But we do have a subset of patients that their syrinx actually gets worse after decompression. And those are the ones that we consider. Or if they had any sort of prior transoral odontodectomy. And so there were some patients in their study that met their criteria kind of before the decompression, and they just ended up getting the suboccipital decompression and a concurrent fusion. But patients that were meeting criteria after decompression had a delayed fusion. So in their study, they were really looking at, this PBC2 line, the clivoaxial angle. And so they were trying to decide, where are these cutoffs that we worry about where somebody is going to be at a higher risk. And their cutoff on the PBC2 line was 9 millimeters, and their clivoaxial angle was 125 degrees. And so, they were also looking at kind of this need for delayed fusion, more likely in Chiari 1.5s, more likely with that medullary kink, more likely in patients that had basilar invagination, and then the PBC2 and clivoaxial angle. So this is sort of their management algorithm. If they do have that complex Chiari, they look at the PBC2 line. If it's less than 9, then they fall into a generally lower risk group, although not 0. If that PBC2 is greater than 9, and that clivoaxial angle is less than 125, so that really sort of flattened platybasia, those are the kids that had the highest risk of fusion. They had like an 83.3% fusion rate. So those are the ones that were really the highest risk. And it doesn't always, over time, we've realized we don't always have to address anything from the front. Usually stabilizing them from the back is sufficient, and they don't necessarily need a transoral odontodectomy. In their cohort, they did have some that had the odontoid reduction as well, if they had persistent symptoms following the fusion. So with that, and that was kind of a whirlwind, it's interesting to talk about Chiari without actually addressing any of the treatment algorithms and just giving a history of Chiari. And our knowledge has really continued to increase over time, not just in the understanding of Chiari malformations in themselves and how different the various features may be, but also in how we think about treating them. And so that'll be addressed in your next lecture. But in general, these Chiari malformations, they are different entities which alter flow of CSF through the foramen magnum. They can also be associated with skull base and spinal abnormalities. The most common, typically Chiari 1 and Chiari 1.5 in the patients that do not have myelomeningocele. In patients with myelomeningocele, we do have Chiari 2. I didn't talk about that much just because from a treatment standpoint, most of these children do not actually require intervention for their Chiari. It's more just knowing that if they start to develop symptoms of their Chiari, you have to think about, is there a problem with their shunt? Is there a problem with their spinal cord retethering? And then several different considerations. As you discovered, it's no longer just this idea that everybody gets a suboccipital decompression. It's, we really have learned a lot more about the potential risks with decompression. I think we're better able to tailor our treatment. You'll learn a little bit more in treatment, our thoughts behind just doing a bone-only decompression versus a duroplasty. And then this subset of complex Chiaris are really the patients that you want to understand what's going on, and really give them a little more thought, because they are at a higher risk following treatment. And it's important to be very upfront about the family when you're having that, because certainly talking to them about the first surgery without talking to them about the potential risk down the line of needing additional surgeries wouldn't be doing anyone any service.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.